palm of the hand. All of the intrinsic muscles of the hand, of course, will have their proximal and distal attachments within the hand. We can start off by making a distinction between two different superficial groups of muscles. There's the thenar group of muscles around here, which is the thenar eminence, and the hypothenar group of muscles around the hypothenar eminence. Then, deep in the hand, which we can't see here yet, is a third group of intrinsic hand muscles. These are called interosseous muscles because they are, as the name suggests, in between the bones of the hand. And there's also another one called the adductor pollicis. That means that would be a muscle that adducts the pollicis, which is the thumb. Before we delve into the muscles, arteries, veins, and nerves of the hand, we have to have a look at some of the bones of the hand. To make this some more fun, we're going to turn to Anatomy TV in just a moment. First off, the most important things: you have 8 carpal bones that you can see down here. You have 5 metacarpal bones right here, and 14 phalanges located up here. Your thumb only has 2 phalanges, a distal and a proximal one, no intermediate or middle phalanx. And we are off to Anatomy TV. First of all, there are 2 rows of carpal bones. Okay, carpus is Latin for wrist. This is the articulation with the radius, the ulna, and the carpal bones that forms the wrist joint. Then you have your metacarpal bones. Meta means next to, between, or in addition to, and you have 5 of these. Here are your phalanges, proximal, intermediate, and distal. Except if you're talking about the thumb, you only have a proximal and a distal one. No intermediate or middle. So again, carpal bone, carpus means wrist. Let's start off by making a good way to remember. Think of the 8 carpal bones as 2 rows of 4. The proximal row, from lateral to medial, is the scaphoid, lunate, triquetrum, and immediately above it, the pisiform. The scaphoid and the lunate actually articulate with the distal part of the radial head. In the next row, you have trapezium, trapezoid, capitate, and hamate. So there are a couple of ways to remember this. One way you can go about this is by thinking of the thumb as a trapeze acrobat. So it kind of swings off the hand in this direction. It's pretty unique, not like any of the other fingers. And so it can swing off to the side. The carpal bones that hold the thumb in its place, though, are going to be called the trapezium and trapezoid. Okay, the trapezoid has a pretty unique shape, and the scaffold is the scaphoid. Yeah, the scaffolding that holds these 2 bones up, that suspend the thumb, is the scaphoid. Lunate means moon, and as you can see, it is quite similar to a full moon, with a little bit of imagination, of course. The pisiform is a pretty unique bone, because it's the only one that sits right on top of another bone, the triquetrum. Pisiform means pea in Latin, and it looks a little bit like a pea. It's about the size of a large pea as well. The capitate is always going to be below the 3rd metacarpal. Think of road rage. Well, right underneath that important finger is going to be the capitate bone. The triquetral, or triquetrum, means 3-cornered. So if you turn it around like this, there's 1 corner, 2, 3 corners. Use your imagination a little bit there. It gets easier if we move distally. You have the 1st metacarpal that suspends the thumb, or pollux. Pollux means thumb in Latin. Then you have 2, 3, 4, 5 metacarpals. Proximal phalanx of thumb and distal phalanx of thumb. Proximal, intermediate, and distal phalanx of index finger. Okay? Easy to remember principle. Okay, so you're going to have to start off by making skin incisions. Check your dissector page 47 how to do this. Note here, you're probably going to have to force open the clenched hand, so you need a dissection partner to help you here. Sometimes it also helps if you have pegboards available to tie the fingers down on the pegboards, then that'll make things much, much easier. We're going to start off with the superficial dissection, and once you've removed the skin, you're going to see that you have your palmar aponeurosis here, which has 4 bands of longitudinal fibers, 1 band to each of the digits number 2, 3, 4, and 5. Okay, these will be attaching to the fibrous-digital sheath near the base of the proximal phalanx of each digit. You'll also see that the thenar and hypothenar muscles are still going to be covered with some fascia, some palmar fascia, which is very thin if you compare it to the palmar aponeurosis. In most of us, you actually also have the palmaris longus tendon, which attaches to the palmar aponeurosis. About 10% or maybe a few more don't have this tendon though. And how it always is with anatomy, if you have a longus muscle somewhere, then you have to have a brevis as well. And this here often gets accidentally dissected out. Here's your palmaris brevis muscle, which will approximately attach right here on the medial aspect of the palmar aponeurosis. Distally, it'll just be attaching to some of the skin here on the hypothenar eminence. If you do find it, cut it off here, detach it, and reflect it medially. In this image, you can see a little bit of a preview of what we're going to be dealing with. Here's your hypothenar eminence, so the little swelling on the hypothenar or on the pinky side of your hand with the hypothenar muscles deep to it, and here on the thumb side of the hand, the thenar eminence here. And your superimposed palmaris longus tendon attaching to the palmar aponeurosis. In the cadaveric dissection, the palmar aponeurosis is going to look something like this. This is an individual, one of the majority that actually also has the associated palmaris longus muscle here. And as I said on the previous slide, here is the palmaris brevis attaching also to the palmar aponeurosis. And we'll be dealing with all of the muscles of the thenar and hypothenar eminences as we move along. Now let's start off with a handy little memory device, how to remember all the muscles of the thenar and hypothenar eminences. This here is not the Three Musketeers, all for one and one for all, no, but this is a mnemonic, which we can use, at least for me, it works pretty well. Let's see how it works. All, abductor pollicis brevis. 4, flexor pollicis brevis. 1, opponens pollicis. And is the adductor pollicis, which is actually being cut in this image. 1, opponens digiti minimi. 4, flexor digiti minimi brevis. All, abductor digiti minimi. That completes all of our important thenar and hypothenar muscles. As we're moving on through the palm, we're now at the superficial part of the dissection where we can see the superficial palmar arch and also the flexor digitorum superficialis tendons. The superficial palmar arch is going to be mainly derived from the ulnar artery, whereas the deep palmar arch is going to be mainly derived from the radial artery. Okay, so find the ulnar artery in the forearm and follow it into the palm. It'll pass lateral to the pisiform bone with the ulnar nerve, when it'll divide into a superficial and a deep branch. The superficial branch of the ulnar artery crosses into the palm to form the superficial palmar arch. There's also a smaller contribution which actually comes from the other side, from the radial artery, but it's not the major contribution. It's a little branch that comes off just about right here. Go ahead and use a probe to clean the superficial palmar arch and 3 of these common palmar digital arteries. A little further distally, they're going to divide into 2 proper digital arteries, each one of these. And they'll be supplying, as you can see, the adjacent sides of 2 digits. Also, go ahead and find the ulnar nerve and dissect out this branch here, the superficial branch of the ulnar nerve. It supplies cutaneous innervation to digit 5 and to the medial side here of your ring finger, digit number 4. The deep branch of the ulnar nerve is going to be disappearing between the hypothenar muscles. See if you can ID the proximal part of this, but don't follow it deeply into the palm. And if you did a really good job on your dissection, this is what it should look like. Here's your ulnar artery going along here, supplying the superficial palmar arch. Here's the branch that turns deep. Here's your ulnar nerve with the superficial parts of the ulnar nerves going to the pinky finger and to the ring finger. Here are your common digital arteries, which then split into proper digital arteries. This is actually a good example right here. Proper, common digital arteries. So next off, you want to identify your flexor retinaculum, and then once you've done that, you're going to go ahead and cut it, as indicated in this picture here. We're going to do this so that we can actually get to the carpal tunnel. If you want to be sure that you don't cut anything that's important deep to it, what you're going to use is a probe, push it deep to the flexor retinaculum, and then cut on top of it with a scalpel. That is always a good approach if you have an area where there are sensitive structures deep to the area being cut. Once you've performed this cut, you have opened the carpal tunnel. Then have a look into the tunnel and you will see that there is the median nerve, 4 tendons of the flexor digitorum superficialis, and 4 tendons of the flexor digitorum profundus. And also the tendon of the flexor pollicis longus muscle is going to be in there. Follow your median nerve through the carpal tunnel and see that it gives off this branch here, which is called the recurrent branch of the median nerve. It innervates the three thenar muscles: abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. The median nerve then continues along here, and it also innervates the lumbrical muscles number 1 and 2. You should be able to follow these common palmar digital branches of the median nerve to the lateral 3½ digits. 1, 2, 3½ because here's the last little branch laterally to the ring finger. The other part is supplied by the ulnar nerve. Have a look at the position of your flexor tendons. You should be able to see that these tendons are going to be posterior to the superficial palmar arch and also to the digital nerves. And these tendons will then enter the fibrous sheaths on the anterior surfaces of the fingers. You should also be able to see that the superficialis and profundus tendons travel in different layers respectively, and one thing you can always do is you can take the fingers and you can flex and extend them. That'll also move these tendons. Then you're going to go ahead and cut the superficial palmar arch right about here in the midline and retract the common digital branches of your median and ulnar nerves as well. Retract them laterally and medially respectively. And see if you can make longitudinal incisions along the palmar surfaces of the fibrous digital sheaths of digits 2, 3, 4, and 5. That should allow you to pull the tendons of the flexor digitorum superficialis distally all the way through the carpal tunnel. Here's a little blue box about carpal tunnel syndrome. Usually a swelling of the common flexor synovial sheath could encroach upon the space that is available in here in the carpal tunnel. The problem with that being is that you also have the median nerve that travels right through here. If you compress the nerve, you will have pain and paresthesia. Paresthesia comes from para and aesthesia, which is strange sensation or abnormal sensation, tingling or pain, as I said, in the index, thumb, and middle fingers, and also weakness of the thenar muscles as these are innervated by the median nerve. Here's an important clinical correlation from clinically orientated anatomy number 7. When your median nerve is severed somewhere in the elbow region, the flexion of the proximal IP joints of digits 1, 2, and 3 is going to be lost, and so the flexion of the 4th and 5th digit is going to be weakened. Flexion of the distal IP joints, so the DIP joints of digits number 2 and 3 is also going to be lost. Flexion of the distal IP joints of number 4 and 5, these two here, is not going to be affected because these are actually the medial part of the FDP, which is innervated by the ulnar nerve. The ability to flex the MP joints of digits number 2 and 3, these two, is going to be affected because the digital branches of the median nerve will supply the first and second lumbricals, which go to these digits. So, when, as in this picture, the person is trying to make a fist, the second and third fingers are going to remain partially extended, forming this so-called hand of benediction. And of course, if you're talking about median nerve injury, you're also going to lose the thenar muscle function, just like in carpal tunnel syndrome. If the anterior interosseous nerve is injured, the thenar muscles are not going to be affected, but you're going to have paresis, which means partial paralysis, of the flexor digitorum profundus and flexor pollicis longus. So, when the person is trying to make the OK sign, like divers do underwater, all okay, opposing the tip of the thumb and the index finger in a circle is not going to work. It's going to look more like this pinch posture here because of the absence of flexion of the interphalangeal joint of the thumb and the distal interphalangeal joint of the index finger. This is because the anterior interosseous nerve is also a branch of the median nerve, but higher up in the forearm. See if you can identify your 4 lumbrical muscles. Here's number 1, 2, 3, and 4. The distal attachment of these muscles is going to be on the radial side of the extensor expansions of digits number 2, 3, 4, and 5. These muscles, when they contract, they all help flex the MP joints and extend the IP joints. In the middle finger, have a look at the relationship of the tendons of your flexor digitorum superficialis and profundus. My mnemonic, or actually rhyme for that, is the superficialis splits in two and profundus passes through. See that the superficialis tendon attaches to the middle phalanx, whereas the tendon of the profundus attaches all the way up here to the distal phalanx. Find your flexor pollicis longus tendon and follow that up into the forearm to the flexor pollicis longus muscle. And see if you can confirm that this tendon all the way down to the thumb again will attach back here to the distal phalanx of the thumb. And so when you pull on this tendon, the thumb should actually flex. Use as much blunt dissection as you can here to clean away some more of the palmar fascia that is overlying your thenar muscles, and really make sure that you preserve this recurrent branch of the median nerve. You should be able to identify all of the thenar muscles. Visible here so far is the abductor pollicis brevis and the flexor pollicis brevis. The abductor will attach to the lateral side of the proximal phalanx of the thumb, and as the name implies, abducts the thumb. And the flexor pollicis brevis attaches to the lateral side of the proximal phalanx of the thumb, and again, as the name implies, flexes the thumb. After you've cut your flexor and abductor pollicis brevis, you should see deep tooth the opponent's pollicis muscle. It will attach to the lateral side of the shaft of the first metacarpal bone, and as the name implies, it opposes the thumb. Have another look at the recurrent branch of the median nerve. It'll cross the superficial surface of the flexor pollicis brevis muscle and then disappear deep to the abductor pollicis brevis muscle. You should be able to take a probe and separate these two muscles from each other, and you can use the recurrent branch of the median nerve to help you do so. Also note that the proximal attachment of the opponent's pollicis muscle is along the flexor retinaculum and tubercles of the scaphoid and the trapezium, whereas its distal attachment site is along the lateral side of the first metacarpal. Moving over to the hypothenar side, you should be able to find three muscles: the abductor digiti minimi muscle, the flexor digiti minimi brevis, and then the opponent's digiti minimi. Check with the dissector for their proximal and distal attachment sites respectively, and lift your abductor digiti minimi up with a probe and cut it off of its proximal attachment on the flexor retinaculum. But make sure to keep the deep branches of your ulnar artery and the ulnar nerve. That should enable you to view the opponent's digiti minimi, which is not in this picture, but it should be in your dissection, and you should be able to see that it'll attach on the entire length of the shaft of the fifth metacarpal bone. Here's one more clinical correlation for us about the recurrent branch of the median nerve. Because this nerve is going so superficially, if you have a cut in the palm of your hand right over the thenar eminence, you could sever this nerve, which would then mean that you would paralyze all of the thenar muscles and you wouldn't be able to oppose the thumb. Going even deeper into the palm of the hand, we can see the adductor pollicis. One important thing about this is it has two heads. It has a transverse head and an oblique head. As you can see by the fiber direction here, if this muscle contracts, it will adduct the thumb, so it'll actually bring it towards the midline. The axial line would here be around your middle finger, so it'll draw the thumb towards the middle finger. Also see that we have interosseous muscles. We have the palmar ones, 3 of these. These are unipennate. And we have 4 bipennate dorsal interosseous muscles. 1, 2, 3, 4. Palmar interosseous muscles adduct the fingers. Pad, P-A-D, pad, palmar, adduct, as you can see in this image on the left. The dorsal interosseous muscles, upon contraction, will abduct the fingers. For details on the proximal distal attachments, please consult your dissector or your atlas of choice. Both sets of interosseous muscles are going to be innervated by the ulnar nerve, specifically actually by the deep branch of the ulnar nerve. Testing the palmar interosseous muscles, you can ask someone to adduct the fingers and try and hold a sheet of paper, for instance, clenched in between the middle and index finger. If you can pull it out easily, maybe they have a weakness in these muscles. Or if you want to test the dorsal interosseous muscles, they're going to have to try and spread their fingers against resistance because the dorsal interosseous muscles abduct the fingers from the midline. If you have an injury to the ulnar nerve, of course, you're going to have a sensory deficit on the region of skin, which is supplied by the ulnar nerve. That is indicated right here. It's 1.5 fingers on the palmar aspect of the hand. But of course, you're also going to have extensive motor loss in the hand, and you're going to lose most intrinsic hand muscles if it is injured distally, which over time can lead to this claw hand-like appearance. Remember that all intrinsic muscles of the hand are innervated by the ulnar nerve except the muscles of the thenar group and the first 2 lumbrical muscles, which are innervated by the median nerve.